Welcome everyone to SimCity Rounds. I'm going to pass over the emceeing for today's meeting to our chief at Providence Healthcare, Dr. Ashley Verdun, because this is one of our amazing rounds, SimCity Rounds, that is also going to be coalesced and merged with the medical grand rounds at Providence Healthcare. So, Ashley.
Thanks very much, Dr. Abdul, and welcome everybody. We're super happy to be here today in this collaborative Grand Rounds. As Dr. Abdul said, this is a combination rounds with our Providence Medical Grand Rounds, and we're very excited to be here today. And I'm very excited to introduce our two speakers, which includes Dr. Abdul today and Samantha Lombardo. Both have been collaborating over the last couple of years on research into education funded through the Bellamy Benuccia Fund at Providence Healthcare. And they're going to talk to us today about their research using virtual reality simulation in a rehab hospital setting to teach suicide risk assessment. So I'm going to introduce them. So I'll start with you, Dr. Abdul. Dr. Petal Abdul is a geriatric staff psychiatrist at the Center for Addiction and Mental Health and a consultation liaison geriatric psychiatrist at Providence Healthcare. She is the Assistant Program Director of International Medical Graduates and an Associate Professor at the University of Toronto in the Department of Psychiatry. She is the inaugural Medical Director of the KMH Simulation Center and a graduate of the CFD Neal and Education Scholars Program. She was appointed the Faculty Lead Simulation Education Integration for the Temerty Faculty of Medicine at the University of Toronto in 2022. Her area of research is simulation and medical education with a special focus on immersive technologies. And Samantha Lombardo is a physiotherapist with over 15 years of practice in geriatrics and medical rehabilitation at Providence Healthcare. She has a special interest in complex care and mental health. As a recipient of the Bellamy Benuccia Research Fellowship at Unity Health Toronto, she has collaborated closely with KMH on this project to advance interprofessional and rehab-focused research and mental health. Samantha is committed to quality patient care and is passionate about broadening awareness of the value of rehab, as well as the role of varied professionals in supporting mental health. Welcome to you both, and we're very much looking forward to your presentation.
Thank you so much, Ashley. I really appreciate that introduction. And we're excited to be here in our February SimCity rounds. As Ashley said, we're going to be talking about using virtual reality simulation in a rehab hospital setting to teach about suicide risk assessment. So in terms of the background, we know that mental illness in Canada impacts 1 in 3 people across their lifetime. And every year, the rate of death by suicide is equivalent to 12 deaths per day. In 2020, the resultant mortality rate was around 10.9 per 100,000 people. In a healthcare setting in particular, patients often present with what we call modifiable risk factors that include new or existing disability, life stressors, homelessness, socioeconomic disparities, and mental health concerns. In a study of suicidal ideation in patients who were hospitalized after a serious illness, 7.3% reported suicidal ideation in the acute phase, and an additional 11% developed it in the 3 to 24 months after. So when we think about a rehab hospital, we know that suicidal ideation has increased, according to the literature, among patients in recent years. And this is not surprising, given that these patients have higher rates of medical complexity, loss of function, and social determinants of health are at stake. They are often more isolated, and they may have issues with their housing as a result of their disability or their changed life circumstance. Health discipline clinicians, which is the term we're going to use for ease of explanation today, would encompass all the staff that work in a rehab hospital setting, social workers, physiotherapists, occupational therapists, and so on. And so our HDCs are often in a position where they can spend significant amount of time with these patients, and they're expected to build rapport with them. And this strong rapport can actually well position them to detect early signs of suicidal thinking. Patients who have that strong therapeutic alliance are therefore more likely to disclose suicidal thoughts to these clinicians rather than to those less involved in their day-to-day care. If our HDCs are trained in comprehensive suicide risk assessment and they have that confidence to apply it, then they can more swiftly recognize and refer patients to enhanced supports in the setting. And while mental health training is often reserved for just the clinicians working in that setting, within a specialized mental health setting, we know that that specialized ability can actually improve patient outcomes and care, and that there is a need for broader mental health education across varied types of care facilities. And clinicians in the rehab setting, which include physiotherapists, rehab assistants, speech language pathologists, recreational therapists, dietitians, pharmacists, social workers, when we look at the curricula that they are trained in, it often lacks that formal training in a suicide risk assessment. And studies show that they tend to rate themselves as having lower levels of confidence in conducting this kind of interview with a patient. So, but yet, despite this, it's an expectation in the hospital setting that patient-facing clinicians should be able to screen for suicidality with patients who may pose any degree of risk. So that brings us to this idea of virtual reality. This has been a proven effective means of clinical education for medical and nursing professionals. And it has shown superior results in the non-technical skills training compared to some of our more traditional didactic methods. Its use is growing in assessment and treatment of mental health conditions in particular. And it really offers an immersive, risk-free environment where learners can make mistakes. We call it failing forward, explore diverse scenarios, and build their skills safely. When you think about Kolb's experiential learning framework, simulation and virtual reality really subscribes to this because it can enhance that connection between the theoretical and the practical. Furthermore, if you incorporate an in-person debriefing and those peer group discussions following the VR session, it can really lead to a solidification of new skills and a boosting of confidence. So the study that we're going to describe to you today evaluates the impact of a virtual reality-based suicide risk assessment, which was developed at the Center for Addiction and Mental Health with a large team. And we're going to use that to train our rehab clinicians, our HDCs, who practice outside the traditional mental health setting. And we're going to focus on how it impacted their knowledge, their confidence, and their intention to change practice. Our hope is that this work can then inform the utility of implementing this kind of training across the board and how it can impact or has the potential to improve clinical care. So when we think about VR in particular in medical education, why are we even going down that road? Well, first, let me start by saying virtual reality, for those of you that are new to it, is the use of any kind of software to create an immersive simulated environment. There are many different things that could be defined as virtual reality. It can include screen-based learning, 360 videos, or the interactive one where you put the headset on and you're moving around in this virtual world. And it's a rapidly emerging field with more and more papers being published every month. It's currently being used widely across medical and nursing fields, and there's a lot of evidence to demonstrate that it's effective. And the benefits are that it's repeatable. I mean, if you had to go and rent an SP and do this, 5, 6 times a week, the cost adds up. And when you use VR, it's standardized, so it can be engaging. You can use it without faculty present in that particular frame of time. It can be integrated into your everyday practice. And at the end, it can actually be more cost effective than a physical simulation in terms of the amount of times you can use it and across the settings. The drawbacks are that it's a newer educational modality. It's not as well studied. And so we know that it might not be suitable for every educational intervention. And we should be selective about when we want to apply it. The other piece is that you need that faculty buy-in, and you need to make sure that they are there to debrief and you have that human in the loop with your technology. It should definitely not replace the expert educator, but rather we should view it as an educational tool that we can use depending on what the need is. So just to give you a bit more insight into the virtual reality suicide risk assessment that we developed, the impetus for this came out of the pandemic and the fact that many of our trainees were not being exposed in the clinical setting to suicidal patients because of, restrictions to room occupancy, and they had to pivot to an online virtual learning space. And so we received a eCampus Ontario grant to build this out with an external vendor. And the learning objectives were created by a huge team of simulation educators and content experts. And we decided that the learning objectives would be to demonstrate the process of building a therapeutic alliance with a patient, identifying the risk and the protective factors during the suicide risk assessment that you're expected to conduct, and then organizing those factors into what we call the 4Ps. Predisposing, so what's putting you at risk? What's precipitating your current suicidal thoughts? Is it a job loss or some acute event that has occurred? What are the perpetuating factors? What is going on in your life that is continually, like, is there a financial stress? Are you homeless? What are these perpetuating factors that are also contributing to your state of mind? And then finally, the last P is protective. What keeps you going? What's holding you back from wanting to end things? And then we ask, with the assistance of a preceptor or a mentor, you're appraising the factors that you've collected and looking at which of these are modifiable, which of these can we assist you with to help get you in a better, safer state of mind. So there were two scenarios that were built. One is Robert Stevens, and that avatar is a 45-year-old male with a lower risk than our second avatar, Michaela Mendez, who is a 19-year-old female who is depicted in this picture here on the slide, and her risk is somewhat higher. So I'm going to share a video with you now, a demo video, just so you could get a sense of what the interface looked like. Just give me a thumbs up, Ashley or Sam, if you can hear.
Hi, welcome. I'm Yasmin, and I'll be your clinical supervisor at our community health clinic. Let's talk about what suicide risk assessments are and what they look like here at the clinic.
That's a strange question.
I don't know. I haven't been feeling like seeing anyone lately. I do have a cat I'm like obsessed with. His name's Oscar.
Well done. Let's go through each factor and determine which of the 4 Ps they relate to. Drag which stickies you think are modifiable risk factors in Rob's life and place them in the bottom portion of the whiteboard. These might be areas to discuss and work on together. What risk level would you assign Rob to help inform an intervention?
Okay, so now I'm going to pass it over to my wonderful colleague, Sam, who is going to share more about the methods of this study.
Okay, so I'll walk everyone through how the study was carried out at Providence. So our team invited health disciplines clinicians at Providence to participate in these small group sessions. It was offered weekly over the summer, and they were all held in our Sim Center at Providence for a total of 41 clinicians who participated. They included PTs, OTs, RAs, social workers, therapeutic rec SLPs, and a few students and clinical externs as well. And then each of the sessions ran with typically 3 to 5 participants at a time. The space was a little bit limited in how many people we could have there at once. But it included first a 15-minute pre-brief discussion to provide some general context, introduce the information about the VR headsets to the users. And then that was followed by a 45-minute virtual reality simulation using the VR headsets themselves. And then a 60-minute debriefing session followed, and that was to allow for some discussion, questions, and knowledge building. You can go to the next slide. So these images are taken from inside the VR module that we just saw, and they show sort of the main areas of focus within the simulation. So learners were in the sim lab all together. They're set up in a square space that is their space to work through on their own. And once they have the headset all set up and they're in the module, they begin in a hospital environment with a virtual educator, as you saw. They're provided with a brief overview of core concepts, including that 4Ps framework that was mentioned: predisposing, precipitating, perpetuating, and protective factors. And then once they're done with that part of the learning, they are then transported within the module into a private assessment room where they conduct a suicide risk assessment with either one or sometimes both, time permitting, of the patient avatars by asking questions and gathering the patient's story. And then finally, the learner is transported back to the main hospital area to debrief with the mentor. So they together will review and organize the assessment findings using the 4Ps framework. And based on that, the outcome of it is to use their clinical judgment and identify what the patient's level of risk would be. So during the sessions, the learners were asked to complete a few brief questionnaires, and that included some basic demographics questions, a survey to assess the learner's level of confidence in conducting the suicide risk assessment, both pre and post training. The simulator sickness questionnaire was to measure symptoms of cyber sickness while using the VR headsets. The user engagement skill short form was to evaluate engagement in the simulation. And finally, a survey about the overall training experience. And then once that data were collected from the 41 learners who completed both the pre and post surveys, it was analyzed with SPSS software, applying simple proportions and a Wilcoxon signed ranks test to evaluate the results. And at this point, I'll hand it back to Dr. Abdool to review the findings.
Thanks so much, Sam. And I'm just going to give you another shout out and say that you really spearheaded this work so well in terms of the delivery. And I'm so grateful to all that you've done to get us to the results phase. So the three largest, if you look at this breakdown of the demographics, we see that the three largest professional roles that were involved in our training were occupational therapists at 34%. Then we had physiotherapists at around 26%, and our rehab assistants were the third largest group. And then in terms of professional career, the majority of them had been working for over 15 years. 43% cited 15 plus years in that setting, and around 15% were working 11 to 15 years, and less than 10% of them were students. So I know that confidence is the lowest rung when it comes to educational evaluation scales, but we do know that it's a step in the right direction in terms of allowing people to think about this sensitive topic and explore. And I think that in the long run, it will have an impact in terms of patient care and outcomes. We see here that we assess pre and post confidence scores, and we looked at it across the 5 learning objectives, and there were gains across all 5. The most substantial was identifying risk factors by conducting a suicide risk assessment. I'm not surprised that there was a tiny jump for the first objective, because we have amazing staff who know how to build a therapeutic alliance with patients. So don't imagine that would have changed a whole lot. But we see that in the areas of identifying the protective factors, there was a huge increase from 2.3 to 3.9. And then determining which of these were modifiable, which is really a skill that you have to practice and think about deeply. And then being able to transmit this information back to your team and to the most responsible physician also jumped from a 3.1 to a 4.1, which is great to see. And then when you think about the Wilcoxon sign rank test, which really looks at whether these changes were significant, we see that learners' confidence scores improved across all 5 domains and that the median post score ranks statistically significantly higher than the pre-score ranks across all 5 topics with P less than 0.01. So I copy and pasted a little preview of what the simulator sickness questionnaire looks like. You see that it's a 16-item scale, and it ranges from none, slight, moderate, and then severe. So, you know, it's really exciting when new technology and innovation comes on, and we want to embrace this and be leaders in the field here in Toronto, but we also want to do it in a cautious and careful way. And we know that everything has its pros and cons. And so with virtual reality, the literature shows that there is a risk of cyber sickness or what we call simulator sickness when you don a headset. And so we wanted to understand that and study it because that obviously will impact who can participate and how the learning will be absorbed. So overall, the total SSQ scores show that the majority of the participants really had none or very minimal simulator sickness symptoms, around 92%. And the mean total score was 5.4, which is pretty good. And when you look at the literature, they say that simulator sickness or VR sickness tends to be around 10 to 30% of participants. So overall, we were doing pretty well. I would say, though, that when we conduct these simulation trainings, we do ask people preemptively and we inform them of the risk. And so perhaps people who would be unwell when they do the training may have opted out or tried the desktop training. So in terms of the user engagement, 39 participants filled this out. And we see that the reward factor was the highest rated category at 4.25. And then learners found the virtual reality platform to be very rewarding, and the overall engagement score was around 3.89. So we did ask other domains, things like perceived usability, like how frustrated were you with using the joysticks or being inside of the headset? What was the visual appeal like? These are all things that we wanted to understand because it can impact how people engage with the training. So in terms of overall experience, there was 41 people filled this out, and we see a whopping 98% felt that they wanted to make changes to their current practice. The themes were across 6 domains using the 4Ps framework. They felt that this would help them to really approach it and categorize the risk more effectively. In terms of increase their use of the suicide risk assessment tools, 6 people felt that they would be more likely to use the tool, and they had raised their sensitivity to this topic. 5 people thought that they would want to ask more detailed questions going forward. So direct quotes were, I would ask different questions and varying questions, question types in different situations. So I think the training may have allowed them to have that renewed confidence and flexibility in terms of how to communicate around this sensitive matter. And then communicating with the team. Someone said, able to communicate my conversations and findings to the team with more structure. And others felt that it increased their awareness and helped them to listen to the patient more empathically. So in terms of the overall simulation experience, 85% of learners agreed or strongly agreed that the simulation enhanced their learning experience. And some quotes that I'll share with you. People felt it was immersive, easy to tune out other distractions in the training room, interactive and engaging. People felt it was realistic, making the situation more realistic and having to quickly adapt to on-time responses. Three people thought it was engaging. It was a great experience. I felt like I was really there, engaging with the patient. And I'll share an experience I had. We were running this with some pharmacy students, and we gave them 45 minutes to interview both avatars. And then we said, it's time to wrap up. And one of the pharmacy students, she came up to me and she said, referring to Michaela, the avatar, is she going to be okay over in there? Because I had to stop when you told me to. And it made me smile because I realized that she had so fully engaged with the patient that she almost forgot that it was an avatar. And I said, don't worry about her. She'll be okay. Let's move to the debrief. But clearly the engagement factor is high with this training. And people also talked about learning at your own pace. And 6 people felt that it made it harder to focus during the training. So not for everyone. In terms of the debriefing experience, we see 97.6% of the learners agreed that the debrief provided them with new insight that they intend to apply to their practice. And these were some quotes that we got. They appreciated having other people's different perspectives. It consolidated and validated what I learned, helped to validate certain concerns we all share regarding our practice. People thought they were helpful additions. An example of the 4 Ps to prime my awareness before the patient conversation. So this is a great example of how we can use simulation to practice before real clinical encounters. And then one person felt validation with the types of resources that are needed for mental health support available to our population at work. So the overall experience was that there was 95% satisfaction, and 95.1 again also thought they would recommend this training to others. So what can we conclude from this? I think we can see that there's been the immersive VR training significantly increased confidence and knowledge in performing suicide risk assessments in a rehab setting. People felt it was rewarding and engaging, and that it really positively influenced their intention to apply these skills on a daily basis. Finally, in terms of the tolerability and the receptiveness, we see that the adverse effects were minimal amongst the participants. And I think that this is really an important step in terms of how we can think about incorporating virtual reality and suicide risk or mental health training in a rehab setting, where we know that clinicians often feel underprepared to assess the suicidal risk. I think one thing we need to keep in mind is that there are some limitations to this study in that it was voluntary. So obviously, the people that signed up may already have interest or may have had deficits or concerns about their confidence and ability to screen for suicide risk. So it doesn't really represent, I think, everyone's perception of how or comfort with conducting suicide risk assessments. And then I think that there is a huge potential when you use this kind of platform to really train a large number of learners. And so we need to really focus our efforts in thinking of how best to implement this in our setting going forward, and potentially in other places as well. So these are our references, and we've finished with a lot of time for questions.
Yes, and feel free to type them in the chat box, or if you want to raise your hand, that's helpful as well, or unmute. I just want to say before we go to the first question, what a fabulous presentation. It's so great to see these results. So thank you to you both for your work on this. I'm really excited. I think this was the first time we've used VR technology for education at Providence. So it was great to see such a positive impact on our staff. So well done. Okay, first question. Sorry, your name is in initials.
Oh, sorry about that. And it won't let me change my name. So the initials stand for the Canadian Interprofessional Health Collaborative, CPIS, is the same en français, in French. My name is Moni Frick. I am a physiotherapist and associate professor at the University of Manitoba in Winnipeg, in the center of North America, geographical center. We don't consider ourselves, in any other center. Two requests. First, can you put up your reference slide again? I'd like to follow up on a couple of the references. Secondly, my question is about the debrief that you did. I want to grab this screenshot before. Okay, perfect. Got it. Thank you. So my question is about the debrief. Two things. Did you use a framework for your debrief?
Yes.
And I'd like to know which. Yeah.
We use the Pearls framework.
Perfect. Okay.
Yeah.
Yeah, I'm familiar with the Pearls framework. Very good. And so did the 41 participants, they did it asynchronously because it was with the VR headset, and then they did it synchronously.
Sam, I'm going to punt this one to you because you delivered this.
And so then how did you do the debrief as the part of the question? If they're doing it, did you bring everybody together into one room? What did the debrief look like?
We kept it in a small group sort of setting. And so I had a maximum of 6 who could be in the space at any given time. And so on average, it was generally somewhere between 3 and 5 people who were there at a time. And so with each of those individual groups, it was a separate debrief.
Okay. That's very helpful.
Yeah.
Thank you. That was super.
Thanks
We're
so
just
much.
starting to embark on VR, and certainly in the physiotherapy program, facing a few challenges in my colleagues in trying to embrace VR, and what that might look like. And then for learners, not for clinicians. But thank you.
So I will say to follow up on that we have shared our VR trainings with across Ontario and beyond, and that not everybody's keen on VR, I find. And so that's why when we built this training, we had the exact same thing in a desktop format so that people have the option to use one or the other. And so I think you want to keep that in mind as well, because it's really beneficial to give that option. And what we found when we published on it with our nursing trainees, our nursing students, the learning experience, the confidence was very comparable for both desktop and VR.
And are you looking to share your desktop version?
Yes, you should reach out to me after this, and we'd be very happy to share.
Again, another interesting topic in rehab for physiotherapists, and what is our role in addressing mental health, which should include assessing suicidal risk, in my opinion.
Absolutely.
Agree.
We've all drank the Kool-Aid.
Does anybody have any other questions for Dr. Abdool or Samantha? I guess perhaps one question I have, as the department head and one of the medical leaders at Providence, is, did you encounter any barriers, do you think, that we would have to think about if we were to implement this education more broadly?
I think whoever's leading the sessions, it ended up being, I would say, generally about 2 hours to 2.5. And so the time commitment can be difficult for people to find the space in their schedules to attend something like that. But I think despite that, and it was during the summer when we were short-staffed, people were still coming and participating very actively and very engaged. And I think if people are willing to engage with the material and learn it, it would draw enough attention. I think if it's a desktop version where people are not getting the opportunity to have the debriefing session after, that's a bit of a loss. Because although you can think about the same questions that would be asked in the framework of the debrief, it was the discussion amongst staff members that was really interesting. And a lot of people did actually have personal experience with this in practice. So having that opportunity to share was really good.
And I would say that to further underscore Sam's point about the importance of a debrief in consolidating learning, and it does not have to be synchronous. So for our nursing students, they did the desktop version, and then they met with a preceptor after as a group, and they discussed what their experience was like. And also you could build in a self-debrief and then have a preceptor-led debrief at a different time. But I think it's essential that you make sure that those components are incorporated to facilitate better learning.
So another question is, have you had any students use the VR version?
Absolutely. Well, Sam's delivery, everybody was in the headset, not so?
I think we had one who transferred out of the headset onto desktop and one for sure who started on desktop, but otherwise everyone was on VR.
Yeah. Yes, it can be. Can be done from home, anywhere you like, from your car, if you have a hotspot. And for the VR, we have the ability to, if you purchase your own headsets, we can share that content with you. And so then you can embed it in your headset as well. So then you have the option to offer your trainees the desktop or the headset.
So there's another question. Is there a plan to scale this training, and what resources are being created to help support that? So I'm not sure if that's a question specific to our site or more broadly, but Dr. Abdool, did you want to comment on who's using this education and how you're spreading it? Sounds like there might be interest too, even from across Canada.
Maybe we could start with the rehab setting with Providence and then work our way out.
Sounds good.
So from my end, during the study, I was the one providing the in-person sessions. And so I had some training experience with the CAMH Sim team. They kind of led me through their process of running the individual sessions. And so I'm not exactly sure what that might look like at Providence going forward, but it would continue to be something that could be offered in a sim center quite easily on site.
Yeah, and I think that should be one takeaway, perhaps, is how we can think about integrating this into our regular education. And perhaps that can be a follow-up from this important work you've both done.
Yeah, and I think the opportunity to share it with newly recruited staff, students at the center, and anyone that perhaps wanted a refresher is where we would hopefully see this moving. And then at CAMH, when we built this virtual reality training, it was with an eCampus Ontario grant. And so one of the conditions of that is that we share it freely with tertiary centers across Ontario. If you're outside of Ontario, then you can connect with us directly and we can come up with a plan for sharing this training. We'd happy to do that. We will say that it has been embedded in the Lawrence Bloomberg Faculty of Nursing curricula. So our nursing students at U of T have done the desktop training. They're in the process of doing a curriculum renewal this year. But we have published on that. We have published data on the students that have done both nursing, both desktop versus headset, and compared the learning, how the learning was received for both modalities.
Wonderful. Anybody else have any thoughts or questions they'd like to share or ask? What a wonderful presentation. Thank you so much. It sounds like very impactful work that you've done and lots of takeaways. So thanks everybody for joining. And Dr. Abdool, do you want to comment on the next rounds?
Oh, yes.
Yeah.
Absolutely. So I don't have the flyer to post, but I will say that we're very excited for next month's rounds because it's an external speaker. It's Jenny Rudolph from Harvard University, and she's going to be coming to present to us on March 25th. Just give me 1 second to pull up the title of her talk. So I really hope that we can get momentum going for Jenny. And as you see, we get a really exciting discussion going. And so my hope is that next month we can all come out and show our enthusiasm for Jenny Rudolph. Sorry, I'm just trying to get the title of her talk. And then we'll give everyone the gift of time. So it's her talk is entitled From Conflict to Collaboration, Cultivating High Trust Duos at Point of Care. And her learning objectives are going to look at how stress and conflict can trigger reactive habits like certainty and indignation, and then using structured conversational frameworks to pause, reset, and shift towards curiosity and respect. And then leveraging micro conversations at the point of care to drive a culture of learning and psychological safety. And you know, Jenny Rudolph has done a lot of work in the area of psychological safety and simulation. So I hope you'll all come out to hear that amazing talk. And thank you so much, Dr. Verdon, for your leadership today in our rounds and for allowing us to do a collaborative rounds with Unity Health Providence.
Our pleasure. All right, everybody. Well, we'll bring this to a close. Thanks, everyone, for joining, and have a great rest of your week.
Thank you. That was very good.